In this video, we'll discuss about iron deficiency anemia. Again, this is a very common condition we see in clinical practice. Basically, people have anemia, which is low hemoglobin, and they have evidence of iron deficiency in the labs. And that's how we make a diagnosis. So let us look at the clinical symptoms of iron deficiency. Most common symptoms include fatigue, weakness, tiredness, lack of endurance, increased sleep. Some people complain of ice eating, which is called pagophagia. Some people feel like eating mud, which is called Pica. There's some changes in the nails, we call it chylonychia. Some people develop a web in the esophagus, leading to difficulty in swallowing. And then some people can even develop behavioral abnormalities. So what are the causes of iron deficiency? The typical, most common cause we see in clinical practice is the blood loss anemia. So people lose blood to the GI tract over the period of time, and they develop anemia, iron deficiency anemia. So the other causes of blood loss because of bleeding into the lungs. Other common cause include some people have heavy periods, we call it menorrhagia, and that can lead to iron deficiency anemia. Some people will be donating blood on a regular basis, and then if they do excess donations, that can lead to iron deficiency anemia, because every time you donate the blood, you are losing iron. So other common cause of iron deficiency include poor diet, malnutrition, and sometimes people have small bowel problems or gastric problems preventing absorption of iron. For instance, people have aclohydria, which means lack of acidity in the stomach, can cause iron deficiency because acid is very important for iron absorption. In addition, patients who had gastric bypass surgery for weight loss can show iron deficiency anemia because, again, the food that they take is bypassing the stomach and going into the small bowel directly. And because the food is not exposed to gastric acid, iron is not absorbed. In addition, conditions such as celiac disease affects the small bowel and duodenum, from where the iron is absorbed the most. And that can lead to iron deficiency. People who take antacids on a regular basis, they don't have acid in the stomach, so that can potentially lead to iron deficiency. Hemodialysis patients also lose iron during the dialysis process and need iron supplements on a regular basis. So what are the stages of iron deficiency? So people with iron deficiency go through like 3 different stages. In the first stage, people have low iron stores in the body. So basically, it's very difficult to diagnose in this stage because there are not all the tests that you do, all the blood tests that you do come back normal. But if you happen to do a test like a bone marrow test, it will show and there are no iron stores in the bone marrow, then you know that patient has iron deficiency. It's very early. You can actually capture iron deficiency in a very early stages, but it's not necessary in clinical practice because it's not practical to do a bone marrow test to diagnose that. And the second stage for iron deficiency is you do the blood test, you do an iron panel, and the ferritin is low. That's the second stage, and the hemoglobin is still normal, they're not anemic. And the third stage in iron deficiency is actually all the iron indices are low. Iron, so they have low ferritin, they have high TIBC, and then the hemoglobin is also low. So that's the final stage of iron deficiency, and that's when we see patients in clinical practice. So how do we diagnose iron deficiency? So typically you run a blood count, which is called CBC, and the hemoglobin is low, and then you run iron indices, which shows low ferritin, low iron saturation, low iron, and then high TIBC. If you look at this blood count, the MCV, the size of the cells will be smaller. We call it microcytosis, like patients have microcytic anemia. So once you diagnose iron deficiency, how do we treat it? So typically, as a general rule, we recommend oral iron supplements if the patient can tolerate it and the iron deficiency anemia is not severe. Because iron is absorbed predominantly in the duodenum and proximal stomach, enteric-coated tablets will not work. You have to take regular iron supplements. So recommend giving iron in an empty stomach because the phosphates, phytates, and tannates that is in the food will bind to iron and prevent its absorption. So it's always better to take iron on an empty stomach or between meals. And iron should be given 2 hours before or 4 hours after antacid intake. Again, antacids will decrease acidity in the stomach and then prevent absorption of iron. So don't try to give iron with antacids. The ferrous form of iron is best absorbed in mildly acidic medium. So usually we recommend taking iron supplements with some vitamin C or using some orange juice to help facilitate iron absorption. The typical doses for replacing iron is 200 milligrams of elemental iron per day, which comes to 65 milligrams 3 times a day. So in each 325 milligrams of iron sulfate tablet has 65 milligrams of elemental iron. So we recommend 325 milligrams ferrous sulfate 3 times a day. Some of the iron preparations such as ferrous gluconate has 36 milligrams of elemental iron, and because it has less elemental iron, it has less side effects. So the side effects depend on the amount of iron in the preparation. The most common side effects you see in clinical practice are GI side effects. Some people complain of constipation, discoloration of the stool, and abdominal bloating, abdominal pain. So if you're experiencing side effects, you go for a preparation which has less elemental iron. So you take either less iron pills or take a preparation which has less elemental iron, such as ferrous gluconate. There is no evidence that one preparation is better than other preparation. If patients have persistent GI side effects, we recommend they take a liquid form of iron, which is ferrous sulfate elixir, which has 44 milligrams of elemental iron in each 5 cc, but the liquid formulation can stain teeth in children, and so we recommend taking that preparation with a straw. So what are the potential iron sources? Heme iron, which is the most available form of iron, is seen in meats and liver. Inorganic iron is seen in a plant-based food, which is spinach, legumes, and fortified grains. Vegetables are generally low in iron. So what are the things that inhibit or prevent absorption of iron? Antacids, antibiotics such as tetracyclines, antibiotics such as quinolones. The other food that can prevent absorption of iron includes cereals, dietary fiber, tea, coffee, eggs, or milk. What is the usual daily requirement for a person? So once you start people on iron supplements, usually it takes hemoglobin will start to go up in a week's time, and it can go up to 2 grams every 3 weeks. And the duration of treatment is up to 6 months after hemoglobin is normalized, so that you are replenishing all the iron stores in the body. So what are the potential side effects of oral iron? Including GI side effects are the most common, including anorexia, means lack of appetite, nausea, vomiting, constipation. Some people can experience diarrhea. So in these people, switching to ferrous gluconate or a liquid form of iron might help decrease the side effects. But if they're not able to tolerate even with this, then we would recommend doing IV iron, especially if they have severe deficiency. So there are some people who do not respond to oral iron supplements. These people include if they have like a potential bone marrow problem, especially if there's an existing malignancy or cancer, or if they have a coexisting folic acid and B12 deficiency, if they have inflammation going on in the body, they may not respond to oral iron supplements. Sometimes the diagnosis is incorrect. Sometimes people with thalassemia or lead poisoning, copper deficiency can mimic iron deficiency. In those people, iron supplements may not help. The most common reason why people do not respond to oral iron therapy is non-compliance, meaning they are not taking the pills on a regular basis. Other common reasons include small bowel problems, where people have malabsorption syndrome. Because of the diseases that affect the duodenum and the small bowel, they're not absorbing the iron. In addition, people who are bleeding on a regular basis will not correct the iron deficiency despite giving all the supplements, because they're losing iron secondary to ongoing bleed. So these are the reasons why people may not respond to oral iron supplements. So in those situations, you may have to switch to IV iron supplements. So in summary, people with iron deficiency can present with anemia, which is very common. They have common side effects such as fatigue or weakness, which can be very disabling. And if they have symptomatic iron deficiency, we try to find the cause and treat the cause. Otherwise, we recommend oral iron supplements. And if they're not able to tolerate the oral iron supplements, or if they're not able to absorb iron, then we consider IV iron supplements. Thank you for watching this video.